Good morning. We're going to talk about conception and fetal development this morning. Very important to have a clear understanding of hormones for this process. Some of the hormones that are needed are estrogen. Estrogen is produced by the ovaries, and later it's produced by the placenta. This helps with the uterus growth and maintains the uterine lining. It increases blood circulation and activates and regulates the production of other key hormones. In early pregnancy, estrogen promotes the growth of breasts. Later on, it helps develop their milk-making machinery. Estrogen also helps regulate the menstrual cycle, controlling the growth of the uterine lining during the first part of the cycle. Progesterone prepares the body for pregnancy in the event that the released egg is fertilized. If the egg is not fertilized, the corpus luteum breaks down, the production of progesterone falls, and a new menstrual cycle will begin. If the egg is fertilized, progesterone stimulates the growth of blood vessels that supply the lining of the endometrium and stimulates glands in the endometrium to secrete nutrients that nourish the early embryo. Progesterone prepares the tissue lining of the uterus to allow the fertilized egg to implant and helps to maintain the endometrium throughout pregnancy. Another important hormone is follicle-stimulating hormone, also known as FSH. It is produced and released by cells in the anterior pituitary gland. In women, this hormone stimulates the growth of ovarian follicles in the ovary before the release of an oocyte from one follicle at ovulation. It also increases the estradiol production. In men, FSH acts on the Sertoli cells of the testes to stimulate sperm production. Luteinizing hormone is produced and released by cells in the anterior pituitary gland. In men, it stimulates Leydig cells in the testes to produce testosterone. In women, in weeks 1 to 2 of the menstrual cycle, luteinizing hormone is required to stimulate the ovarian follicles in the ovary to produce the female sex hormone, estradiol. Around day 14 of the cycle, a surge in luteinizing hormone levels causes the ovarian follicle to tear and release a mature oocyte from the ovary. For the weeks 3 to 4 of the cycle, the remnants of the ovarian follicle form a corpus luteum. Luteinizing hormone stimulates the corpus luteum to produce progesterone. Two phases of the ovarian cycle. The follicular phase are days 1 through 14. A follicle matures and ovulation occurs. The second phase is the luteal phase. It begins on day 15, goes through day 28. Begins when the ovum leaves the follicle and the corpus luteum develops from a ruptured follicle. This is an image of the female reproductive cycle. And you'll see how the follicle stimulating hormone and luteinizing hormone have an effect on the estrogen and progesterone levels. There are 4 phases of the menstrual cycle: the menstrual, the proliferative, secretory, and ischemic. Menstruation is initiated each month by falling levels of estrogen and progesterone and the release of prostaglandins, which constrict the spiral arteries. This causes them to spasm, contract, and break up. The blood supply to the endometrium is cut off, and the cells of the top layer of the endometrium become deprived of oxygen and die. The layer is then lost. During the proliferative phase, it's the second phase of the uterine cycle when estrogen causes the lining of the uterus to grow and proliferate. The secretory phase occurs from day 14 to day 28 of the cycle. Progesterone stimulated by luteinizing hormone is the dominant hormone during this phase to prepare the corpus luteum and the endometrium for a possible fertilized ovum implantation. During the proliferative phase, the endometrial cells enlarge and become twisted and longer under the influence of estrogen, and the endometrium thickens 6 to 8-fold. Cervical mucosa becomes thin, clear, watery, and more alkaline. During the secretory phase, this follows ovulation. Progesterone causes marked swelling and the amount of tissue glycogen increases. Vascularity of the entire uterus increases greatly, providing a nourishing bed for implantation. If implantation does not occur, the body will go through ischemic phase. The corpus luteum begins to degenerate, estrogen and progesterone levels fall, and this phase is characterized by the escape of blood into the stomach cells of the uterus. Teratogenesis. An embryo is the most vulnerable during the first 8 weeks of cell differentiation and organ system development. The effects of teratogens, drugs, viruses, radiation, depend on the maternal and fetal genotype, the stage of development when exposure occurs, and the dose and duration of exposure to an agent. Factors that may affect embryonic development include the quality of the sperm or ovum from the zygote from which the zygote was formed, the genetic code established at fertilization, and the adequacy of the intrauterine environment. If the environment is unsuitable before cellular differentiation occurs, all of the cells of the zygote are affected. The cells may die, which causes spontaneous abortion, or growth may be slowed, depending on the severity of the situation. When differentiation is complete and the fetal membranes have formed, an injurious agent has the greatest effect on those cells undergoing the most rapid growth. Thus, the time of injury is critical in the development of anomalies. Health measures to address in preconception counseling. Modifiable risk factors include smoking, alcohol, social and street drugs, caffeine, medications, and environmental hazards. Smoking causes vasoconstriction that can interfere with placental circulation. The infant may suffer negative effects, including intrauterine growth restriction and lung problems, and smoking should be avoided during pregnancy. This goes with many of the other modifiable risk factors, so educating patients prior to pregnancy is very important. Most patients do not realize they're pregnant during those first few weeks, so this is the critical time to avoid those modifiable risk hazards that can cause birth defects. Mitosis. It's the process of cellular division. You have somatic cells. The parent cell divides into 2 daughter cells that are exact copies of the original cell. Each daughter cell has its own nucleus, identical to parent cell and to each other. One cell divides and turns into 2 identical cells that are identical to the original cell. They contain the same diploid number of chromosomes or genetic material, so 46 chromosomes. During pregnancy, you'll see cell division caused by meiosis. cell division that produces reproductive cells called gametes, sperm and ova. Each cell contains 23 of different genetic materials of the parent cell, haploid cell. Meiosis consists of two successive cell divisions. The first division, the chromosomes replicate. The second divisions, the chromatids of each chromosome separate and move to opposite poles in each of the daughter cells. In meiosis, the cellular division results in formation of 4 cells. Each cell contains 23 haploid number of chromosomes. The daughter cells contain only half of the DNA of a normal somatic cell. A pairing takes place between a homologous chromosome instead of separating immediately, as in mitosis. The chromosomes become closely intertwined. At each point of contact, there is a physical exchange of genetic material between the chromatids, or arms of the chromosomes. New combinations are provided by the newly formed chromosomes. These combinations account for a wide variation of traits in people, such as hair or eye color. The sex of a baby is always determined by the father. The mother will always put out an X chromosome or a female chromosome, but the males during this cycle will either give you an X or a Y chromosome, and that's how the sex of a baby is determined. This next slide shows a picture of mitosis versus meiosis side by side. You can see that they're very different cell division. Mitosis makes growth and development possible, and in mature individuals is a process by which our body cells continue to divide and replace themselves. Meiosis produces reproductive cells, gametes. Reduction of chromosomes from diploid 46 to haploid 23, so that when fertilization occurs, the normal diploid number is restored, introduces genetic variability. Chromosomal mutations may occur during the second meiotic division. The still paired chromatids are carried into one of the daughter cells and eventually form an extra chromosome, or chromosomes break during meiosis. Process of gametogenesis. This is the process by which germ cells or gametes, ovum and sperm, are produced. These cells contain only half the genetic material of a typical body cell. Each gamete must have only the haploid number, or 23, of chromosomes, so that when the female gamete, egg or ovum, and the male gamete, sperm or spermatozoon, unite to form a zygote, or a fertilized ovum. The normal human diploid number of chromosomes, 46, is half from the mother, half from the father, and it's reestablished during gametogenesis. Oogenesis is a process that produces the female gamete called the ovum, or egg. Ovaries begin to develop early in the fetal life of the female. Ovary gives rise to oogonial cells, which develop into oocytes. During puberty, mature primary oocyte continues through first meiotic division in ovary, one cell turning into 2 different cells. The haploid cells are released at ovulation. All of the ova that a female will produce in her lifetime are present at birth. Meiosis, or cell replication by division, begins in all oocyte before the female fetus is born, but stops before the first division is complete and remains in this arrested phase until puberty. During puberty, the mature primary oocyte proceeds by oogenesis through the first meiotic division on the Graafian follicle of the ovary. The first meiotic division, still in the ovary, 2 cells of unequal size produced with the same number of chromosomes. One cell is secondary oocyte, other is minute polar body. Secondary oocyte and polar body each contain 22 double-structured autosomal chromosomes and one double-structured sex chromosome, or X chromosome. At the time of ovulation, the second meiotic division begins immediately and proceeds as oocyte moves down the fallopian tube. Division is again not equal, and the secondary oocyte moves into the metaphase stage of cell division, where the meiotic division is arrested until and unless the oocyte is fertilized. The second polar body, also haploid, forms at this time. The first polar body has now also divided, producing two additional polar bodies, thus the completion of meiosis. 4 haploid cells have been produced, the 3 polar bodies, which will eventually disintegrate, and 1 ovum. Spermatogenesis. That's the production of the male gamete or sperm during puberty. The spermatogonium primordial germ cell begins with complete set of genetic material, a diploid number of chromosomes 46. The cell replicates before it enters the first meiotic division. Cell is now primary spermatocyte. The spermatogonium or primordial germ cell. During the first meiotic division, spermatogonium forms 2 cells called secondary spermatocytes. Each contains 22 double-structured autosomal chromosomes and either double-structured X sex chromosomes or double-structured Y sex chromosomes. During second meiotic division, divide to form 4 spermatids, each with haploid number 23 of chromosomes. Spermatids undergo a series of changes, lose most of their cytoplasm, and become sperm. The spermatids undergo a series of change during which they lose most of their cytoplasm and become sperm. The nucleus becomes compacted into the head of the sperm, which is covered by a cap called an acrosome that is in turn covered by a plasma membrane. The long tail is produced from one of the centrioles. Figure 12.1 shows a picture of gametogenesis. To develop ova in females and spermatozoa in males, gametogenesis, the creation of reproductive cells, requires a special reduction division called meiosis. Unlike mitosis, in which the diploid number of chromosomes 46 is retained in each new cell, meiosis halves the number of chromosomes, becoming a haploid number, or 23. Only one of each chromosome in a pair is directed to the gamete, yielding 22 chromosomes and 1 sex chromosome. When the sperm and ovum unite in contraception, the halves form a new cell and restore the chromosome number to 46. Preparation for fertilization. The ovum is released into the fallopian tube. The ova is considered fertile for 12 to 24 hours after ovulation. It's viable for 48 to 72 hours after in vaginal tract, healthy and highly fertile for 24 hours. The ovum does not move. Peristalsis of the fallopian tube and thinning of the cervical mucus occur. Fertilization occurs in the ampulla, or the outer third of the fallopian tube. The male deposits approximately 200 to 300 million spermatozoa into the vagina in a single ejaculation. Only 300 to 500 sperm actually reach the ampulla. Sperm can survive in the female reproductive tract for 72 hours. The ovum has no inherent power of movement. During ovulation, high estrogen levels increase peristalsis within the fallopian tubes, which helps move the ovum through the tube toward the uterus. The high estrogen levels also cause a thinning of the cervical mucus, facilitating movement of the sperm through the cervix. into the uterus and up the fallopian tube. Fructose in the semen secreted by seminal vesicles is the energy source for sperm. Transit time from the cervix into the fallopian tube can be as short as 30 minutes to as long as 6 days. Prostaglandins in the semen may increase in uterine smooth muscle contractions, which help transport the sperm. The fallopian tubes have a dual ciliary action that facilitates movement of the ovum toward the uterus and movement of the sperm from the uterus toward the ovary. The sperm must undergo 2 processes before fertilization can occur: capacitation and acrosomal reaction. Capacitation is a removal of plasma membrane overlying the spermatozoa's acrosomal area and the loss of seminal plasma proteins. If the glycoprotein coat is not removed, the sperm will not be able to fertilize the ovum. Capacitation occurs in the female reproductive tract, aided by uterine enzymes, and is thought to take about 7 hours. Sperm that undergo capacitation now take on 3 characteristics: the ability to undergo the acrosomal reaction, the ability to bind to the zona pellucida, and the acquisition of hypermotility. The acrosomal reaction follows capacitation, whereby the acrosomes of the sperm surrounding the ovum release their enzymes: hyaluronidase, a protease called acrosin, and a trypsin-like substance, and thus breaks down the hyaluronic acid in the ova. For this reason, in combination of situations, conception, it is best to have intercourse several days around ovulations. That gives the best situation for conception to occur. Sperm penetration causes chemical reaction that blocks more sperm penetration. Sperm enters the ovum. Chemical signal prompts secondary oocyte to complete second meiotic division. True moment of fertilization occurs as the nuclei unite. Chromosomes pair up to produce a diploid zygote. Each nucleus contains a haploid number of chromosomes, 23. The union restores diploid number 46. A zygote contains a new combination of genetic material. The sex of the zygote determined at moment of fertilization. 2 chromosomes of 23rd pair sex chromosomes, either XX or XY, determine the sex of individual. Females will have 2 X chromosomes, and males will have an X and a Y chromosome. When each gamete contributes an X chromosome, the resulting zygote is female. When the ovum contributes an X and the sperm contributes a Y chromosome, the resulting zygote is a male. Certain traits are termed sex-linked because they are controlled by the genes of the X chromosome. 2 examples of sex-linked traits are colorblindness and hemophilia. This is a picture of sperm penetration of an ovum. It's a scanning electron micrograph of a human sperm surrounding the human ovum at 750 times. The smaller spherical cells are granulosa cells of the corona radiata. Pre-embryonic development stage. The pre-embryonic stage, the first 14 days of development, starting the day the ovum is fertilized or conception. Cell multiplication. The zygote is rapid mitotic division, blastomeres, or divided cell grow to the merolla, a solid ball of 12 to 32 cells. The merolla divides into a solid mass or blastocyte surrounded by an outer layer of cells called the trophoblast. Implantation occurs in 7 to 10 days. Cellular multiplication begins as the zygote moves through the fallopian tube toward the cavity of the uterus. This transport takes 3 days or more and is accomplished mainly by a very weak fluid current in the fallopian tube resulting from the beating action of the ciliated epithelium that lines the tube. The outer layer of cells that surround the cavity and replaces the zona pellucida is the trophoblast. The trophoblast develops into one of the 2 embryonic membranes called chorion. The inner solid mass of cells, called the blastocyte, develops into a double layer of cells called the embryonic disc, from which the embryo and the amnion, embryonic membrane, will develop. Cell differentiation occurs 10 to 14 days. Ectoderm, mesoderm, and endoderm, from which all tissues, organs, and organ systems develop. The blastocyte differentiates into 3 primary germ layers, the ectoderm, mesoderm, and endoderm. All tissues, organs, and organ systems develop from these primary germ cell layers. Embryonic membranes form at implantation, nidation, the chorion, and the amnion. Figure 12.4 shows the formation of primary germ layer. A is the implantation of a 7.5-day blastocyte in which the cells of the embryonic disc are separated from the amnion by a fluid-filled space. The erosion of the endometrium by the syncytiotrophoblasts is ongoing. B shows implantation is completed by day 9, and the extraembryonic mesoderm is beginning to form a discrete layer beneath the trophoblast. C shows by day 16, the embryo shows all 3 germ layers, a yolk sac and an allantois, which is an outpatching of the yolk sac that forms the structural basis of the body stalk or umbilical cord. The cytotrophoblast and associated mesoderm have become the chorion. The chorionic villi are developing. The blastocyst, now floating in the uterine cavity, is nourished by the uterine glands, which secrete a mixture of lipids, mucopolysaccharides, and glycogen. The trophoblast attaches itself to the surface of the endometrium for further nourishment. The most frequent site of attachment is to the upper part of the posterior uterine wall. Between days 7 and 10 after fertilization, the zona pellucida disappears and the blastocyst implants itself by burrowing into the uterine lining and penetrating down toward the maternal capillaries until it is completely covered. Under the influence of progesterone, the endometrium increases in thickness and vascularity in preparation for implantation and nutrition of the ovum. Cell differentiation. Amniotic fluid. Amnion and chorion grow and connect and form an amniotic sac to produce fluid. The yolk sac develops as part of a blastocyst, produces primitive red blood cells, and soon is incorporated into the umbilical cord. The embryonic membranes begin to form at time of transplantation. The first and outermost membrane to form is the chorion. This thick membrane develops from the trophoblast and has many finger-like projections called chorionic villi on its surface. It is used for early genetic testing of the embryo at 8 to 11 weeks. The second membrane to form, the amnion. The amnion is a thin protective membrane that contains the amniotic fluid. The primary functions of amniotic fluid are to act as a cushion to protect the embryo against mechanical injury and to help control the embryo's temperature. This relies on the mother to release heat. With every pregnancy, there is an opportunity or a chance that there may be twin development. Fraternal twins, or dizygotic, form from two separate ova fertilized by two separate spermatozoa. It will have two placentas, two chorions, and two amnions. Sometimes placentas fuse and appear to be one. Fraternal twins are no more similar to each other than singly born siblings. They may be of the same or different sex. Twins normally occur in approximately 33.2 per 1,000 live births in the United States. That is fraternal or identical combined. Dizygotic twinning increases with maternal age up to the age of 35 and then decreases abruptly. Dizygotic is a male and a female twin. So those of male and a female twin will always be two separate ova fertilized by two separate spermatozoa. The current rate of twinning is attributed to delayed childbearing and the use of artificial reproductive treatments. In the next slide, you'll see the formation of fraternal twins. Two ova, two blastocytes, two amnion, two chorion. Identical or monozygotic twins develop from a single fertilized ovum. They are of the same sex and have the same genotype. Identical twins usually have a common placenta. Monozygosity is not affected by environment, race, physical characteristics, or fertility. Both fetuses are same sex with same characteristics. Monozygotic twins originate from the division of a fertilized ovum at different stages of early development. The number of amnions and chorions present depends on the timing of that division. Division within 4 days after fertilization, and that's about 25% of the time. There's two embryos, two amnions, two chorions. The amniotic sacs will eventually be covered by a common chorion. The monochorionic diamniotic placenta. If division occurs about 4 to 8 days, two embryos, a separate amnion sac called a placenta. If amnion R is already developed, division 8 through 12 days after fertilization, two embryos with common amniotic sac and common chorion. Monochorionic monoamniotic placenta. This is rare and only occurs about 1% of the time. Monozygotic twins originate from the division of a fertilized ovum at different stages of early development. After the zygote consists of thousands of cells. Division will occur within 4 days, 25% of the time. Monozygotic twinning is considered a random event and occurs in approximately 3 to 4 per 1,000 live births. Survival rate of monozygotic twins as a group is 10% lower than that of dizygotic twins, and congenital anomalies are more prevalent. Both twins may have the same malformation. Formation of identical twins. You will see in this image, there's one ovum, one sperm, one blastocyte. The inner cell mass splits into two, and you'll see two amniosacs, one chorion. Big difference. The umbilical cord. The umbilical cord is being formed from the amnion as the placenta develops. The body stalk fuses and the embryonic portion of the placenta provides circulatory pathways from the chorionic villi to the embryo. Vessels in the cord decrease to one large vein and two smaller arteries. A specialized mucoid connective tissue surrounds the blood vessels known as Wharton's jelly. This jelly helps to prevent any injuries or breaking away. It's kind of a cushion. Central insertion into the placenta is considered normal. An umbilical cord has no sensory or motor innervation. Average cord is 2 centimeters or 0.8 inches across and about 55 centimeters or 22 inches length. This tissue, plus the high blood volume pulsating through the vessels, prevents compression of the umbilical cord in utero. Umbilical cords appear to be twisted or spiraled, which is most likely caused by fetal movement. A true knot in the umbilical cord rarely occurs. If it does, the cord will be longer than usual. More common are so-called false knots caused by the folding of cord vessels. A nuchal cord is said to exist when the umbilical cord encircles the fetal neck. About 1 in 200 umbilical cords have only 2 vessels, 1 artery and 1 vein. This condition may be associated with congenital malformations, primarily of the renal, gastrointestinal, and cardiovascular system. Next is a picture of the umbilical cord. The first picture shows the 2 small arteries and the 1 large vein. The next picture is the picture of the placenta, and this is the baby side of the placenta and the cord running to where the baby's umbilical is. The next structure is the placenta. Placental development begins at 3rd week of embryonic development. Develops at site where embryo attaches to the uterine wall. Its function is metabolic and nutrient exchange between embryonic and maternal circulations. The placenta has 2 parts, the maternal and the fetal. The placenta enlarges until the 20th week. This continues to supply nutrients and metabolic activity between the fetus and the maternal circulation. Smoking constricts the blood vessels and decreases circulation to the fetus. Smoking causes vasoconstriction that can interfere with placental circulation. The infant may suffer negative effects, including intrauterine growth restriction, causing lung problems, and should be avoided during pregnancy. The next image shows the maternal portion. This is where it attaches to the mother's uterus. It consists of this decidua bacillus and its circulation. The surface appears red and flesh-like. The fetal portion has a white color. It consists of the chorionic villi and their circulation. The reason for the white appearance is the surface is covered by amnion. It appears shiny and whitish gray. The completion of the maternal placental embryonic circulation occurs about 17 days after conception, when the embryonic heart begins functioning. By 14 weeks, the placenta is a discrete organ. It produces glycogen, cholesterol, and fatty acids continuously for fetal use and hormone production. Fetal blood flows through the 2 umbilical arteries to the capillaries of the villi, and oxygen-enriched blood flows back through the umbilical vein into the fetus. The next image is an embryo at 5 weeks. The embryo has a marked C-shaped body and rudimentary tail. The stage of embryo starts on day 15, the beginning of the 3rd week after conception, and continues until approximately 8th week. Tissue differentiate into essential organs and the main external features develop. The embryo is the most vulnerable to teratogens during this period. At 3 weeks, a single tubular heart forms just outside the body cavity of the embryo. At 5 weeks, the optic cups and lens vessels of the eye form and the nasal pits develop. By day 35, the arm and leg buds are well developed. The heart, circulatory system, and brain show the most advanced development. The brain has differentiated into 5 areas, and 2 pairs of cranial nerves are recognizable. At 4 weeks, the fetus is 4 to 6 millimeters. The brain formed from anterior neural tube and the limb buds are able to be seen. The heart will beat and the GI system begins to work. At 6 weeks, it's 12 millimeters, the primitive skeletal shape, the chambers in the heart, the respiratory system begins, ear formation begins. At 12 weeks, it's 8 centimeters. Ossification of the skeleton begins. Liver produces red cells. The palate is complete in the mouth. The skin is pink. The thyroid hormone is present, and insulin is present in the pancreas. At 16 weeks, the fetus is 13.5 centimeters. Teeth begin to form. Meconium begins to collect in the intestines. Kidneys assume their shape, and hair is present on the scalp. At 20 weeks, fetus is 19 centimeters. The myelination of the spinal cord begins. Suck and swallow begins. Lanugo will cover the baby's body, and vernix begins to protect the body. So at 20 weeks, your baby's going to have tiny little hairs covering the body to protect it. Surfactant production begins and the brain appears mature. This is what your fetus would look like at 20 weeks. The fetus weighs 435 to 465 grams, or about 16 ounces, and measures about 19 centimeters, or 7.5 inches. Subcutaneous deposits of brown fat make the skin a little less transparent, and woolly hair may cover the head, and nails have developed on the fingers and toes. At 28 weeks, the fetus is 27 centimeters. Nervous system begins regulation of some functions. Adipose tissue accumulates. Nails, eyebrows, and eyelids are present, and the eyes are open now. 36 weeks, 35 centimeters. Earlobes are soft with little cartilage, and few soul creases are present. At 40 weeks, where fetus will be 40 centimeters, have adequate surfactant, vernix in the skin folds, and lanuga on shoulders. Earlobes are firm, and the sex is apparent. Weight is about 6 pounds 10 ounces to 7 pounds 15 ounces. This will vary in different ethnic groups. Skin has a smooth, polished look. Hair on head is coarse and about 1 inch long, and body and extremities are plump. The fetus is considered full term at 38 weeks and up to 40 weeks after conception. Fetal development, what parents want to know. The fetal heartbeat begins at 4 weeks. At 8 weeks, all body organs are formed. 6 to 12 weeks, the fetal heart rate can be heard by ultrasound Doppler device. At 16 weeks, the baby's sex can be seen. Although thin, the fetus looks like a baby. At 20 weeks, the heartbeat can be heard by fetoscope. The mother feels movement or quickening. The baby develops a regular schedule of sleeping, sucking, and kicking. Hands can grasp. Baby assumes a favorite position in utero. And vernix caseosa, lanolin-like covering, protects the body. And lanuga, fine hair, keeps oil on the skin. Head, hair, eyebrows, and eyelashes are all present. At 24 weeks, the baby weighs about 1 pound 10 ounces. Activity is increasing. Fetal respiratory movement begins, and the baby makes sucking movements. At 28 weeks, eyes are open and close. Eyes will open and close. Baby can breathe at this time. Surfactant needed for breathing at birth is formed. Baby is 2/3 of its final length. At 32 weeks, baby has fingernails and toenails. Subcutaneous fat is being laid down. Baby appears less red and wrinkled. And at 38 plus weeks, the baby feels total uterus. The baby gets antibodies from its mother at that time. The next slide shows some images of babies at different. My pictures did not come across. I'll share them in class. But at 12 weeks, your baby, the baby will be 2.13 inches or so, weigh 2.05 ounces. At 16 weeks, baby will be 7.3 inches and weigh about 5 ounces. 20 weeks, they're about 10 inches and weigh just under 12 ounces. At 24 weeks, baby will be 12, almost 13 inches and weigh a pound, close to a pound and a half. At 28 weeks, baby will be 14.8 inches and weigh a little over 2 pounds. At 32 weeks, baby should be about 17 inches and weigh around 4 pounds, just under. That is it. Have a good day.